Good afternoon. My name is Jarrett Castanedi, Capacity Building Coordinator for the AIDS Education and Training Center's National Center for HIV Care in Minority Communities. Before we begin today's webinar, Clinical Webinar number 6, Introduction to Antiretrovirals, Part 3 of 3, I would like to introduce you to today's presenter, Dr. Mirta Soto-Rosario. Dr. Soto-Rosario is a doctorally prepared pharmacist who serves as a clinical consultant for the AETC and CHCMC. She has no relevant financial relationships with commercial interests, nor discusses unlabeled or unapproved uses of drugs or devices during the presentation. Dr. Soto-Rosario?
Thank you, Jared, and good afternoon. I'm happy to be with you again to continue our discussion of the antiretrovirals. We are now at the third and final webinar that covers the antiretroviral medications. Throughout these 3 webinars, we have discussed the goals of antiretroviral therapy, and during this last webinar, we will be describing additional antiretroviral drug classes and their pertinent clinical considerations. During this webinar, we will be discussing the following ARV drug classes: the protease inhibitors and the CCR5 antagonists. The highlighted medications are those we will be discussing in greater detail this afternoon. The protease inhibitors are the medications we'll be discussing next. Protease inhibitors target the virus at the point in which the long protein strands are being cleaved into functional proteins. The protease enzyme facilitates the formation of a fully mature functional virus. Protease inhibitors interrupt the later steps of the viral life cycle. They inhibit the protease enzyme, which would then cleave the long protein strands into functional proteins, which are further cleaved and go on to form infectious viral particles. They have a higher genetic barrier, the protease inhibitors, to resistance than do the NNRTIs and Reltegravir, the integrase inhibitor. When a patient experiences virologic failure on their first protease inhibitor regimen, resistance is uncommon. These medications are also metabolized via the cytochrome enzyme system. As a result, there are many drug interactions with this drug class. As a class, the protease inhibitors are known to cause hyperlipidemia, fat redistribution, hepatotoxicity, GI intolerance, which many people complain of and can affect adherence. These medications do increase the risk of bleeding in certain patients, and like I mentioned before, they are prone to many drug interactions. Ritonavir, RTV, brand name Norvir, has an approved dose of 600 milligrams twice daily. This is not the dose used in clinical practice, as its primary role is as a booster drug, which is dosed based on the concurrent protease inhibitor and can range from 100 to 400 milligrams daily. This medication is available as a liquid, capsule, and tablet. The liquid and soft gel formulations require refrigeration, while the tablets do not. This medication's place in therapy is as a pharmacokinetic enhancer. In patients taking the protease inhibitor, when you boost the drug's levels with Ritonavir, you reduce the chance of developing resistance as a result of suboptimal drug exposure. In addition, Ritonavir boosting prolongs the half-life of the concurrent protease inhibitor, which allows for less frequent dosing, which can improve adherence. And it's found that less frequent dosing can improve medication adherence, and that's one of the big factors to get patients to take their medications. An important clinical consideration, especially in patients with multiple comorbidities, fluticasone is one medication that's co-formulated along with long-acting beta agonists for asthma, and is a single entity product for nasal allergies as well. If co-administered, higher than normal amounts of the steroid are systemically absorbed, which can predispose someone to develop Cushing-like syndromes. One alternative is flunisolide or mometasone. There are many drug interactions with Ritonavir, and this is just one of the examples. And I've mentioned before, because it is metabolized by the cytochrome P450 enzyme system, and Norvir, or Ritonavir, is a CYP3A4 inhibitor. I would encourage you to look at the Table 15A of the DHHS guidelines for a more comprehensive list of the drug interactions. Atazanavir, ATV, brand name Reyataz, is dosed 400 milligrams daily or 300 milligrams with 100 milligrams of Ritonavir in treatment-experienced patients or in those patients taking Tenofovir. This protease inhibitor has the advantage of once-daily dosing. Ritonavir enhances the concentrations of Atazanavir and demonstrates similar efficacy as unboosted Atazanavir in treatment-naive patients. There are no dose adjustments needed in patients with renal dysfunction. However, it is not recommended for treatment-experienced patients on hemodialysis. Also, boosting with Ritonavir is not recommended in patients who have severe liver dysfunction. This protease inhibitor is a CYP3A4 substrate and inhibitor. It is considered a lipid neutral, it's lipid neutral. However, that's clearly at the 400 milligram dose in which it is unboosted. It is not clear whether its lipid neutral benefits remain when it is boosted with Ritonavir. This medication interacts with warfarin, anticonvulsants, clarithromycin, amiodarone, the beta blockers, rosuvastatin, calcium channel blockers, and medications that are contraindicated with Atazanavir are listed below. For a more comprehensive list of drug interactions, I encourage you to review Table 15A of the DHHS guidelines. A very important drug interaction with this medication is that with antacids, H2 antagonists, and proton pump inhibitors. With antacids, Atazanavir should be given at least 2 hours before or 1 hour after the antacids. The H2 receptor antagonist doses should not exceed the equivalent doses of famotidine of 40 milligrams twice daily. It is recommended to give Atazanavir boosted with Ritonavir at least 2 hours before the H2 blocker or 10 hours after. The proton pump inhibitor doses are not to exceed 20 milligrams of omeprazole daily and should be given at least 12 hours prior to Atazanavir. In addition, it should always be given boosted with Ritonavir when it's co-administered with the proton pump inhibitors. This is a very important counseling point, as patients may be purchasing these medications over the counter without a prescription and may not mention them unless specifically asked about concurrent over-the-counter medications and herbal supplements. Unlike Atazanavir, in which Ritonavir's inhibitory effects are beneficial, Darunavir requires co-administration with Ritonavir for efficacy. The dose of Darunavir also depends on whether a patient is treatment-naive or experienced. For a treatment-naive patient, the dose is 800 milligrams daily with 100 milligrams of Ritonavir. For a treatment-experienced patient, the dose is 600 milligrams twice daily with 100 milligrams of Ritonavir twice daily. This medication also requires food for absorption and has been proven to have potent virologic efficacy when compared to other protease inhibitors. This medication is not recommended in patients with severe hepatic impairment. It is also a CYP3A4 substrate and inhibitor, and as a result has many drug-drug interactions. Listed here are the medications that should not be used at any dose and are contraindicated with Darunavir. As a class, protease inhibitors interact with the statin medications, and they're all contraindicated with simvastatin. Darunavir should not be co-administered with pravastatin, which is a suitable alternative in patients who may be on other protease inhibitors. Fosamprenavir, FPV, brand name Lexiva, has multiple dosing options available depending on whether a patient is treatment experienced or treatment naive. It can be given 1,400 milligrams twice daily without Norvir. It can be given 700 milligrams plus Ritonavir, 100 milligrams twice daily, or it can be given the 1,400 milligrams with Ritonavir, 100 to 200 milligrams once daily. And that's for treatment naive. With the treatment experienced patients, you'll note that there are no options to take Fosamprenavir without the boosted Ritonavir. The food requirements for Fosamprenavir depend on which dosage form the patient is taking. Tablets can be taken without regards to meals. However, the oral suspension should be taken with food, and if co-administered with Ritonavir, it should also be given with food. Because hyperlipidemia frequently occurs, baseline and regular monitoring of lipids should also be done. This medication requires dose adjustment in patients with moderate hepatic impairment. Please see Appendix B, Table 7 of the guidelines, of the DHHS guidelines for specific recommendations on the dosage adjustments for hepatic impairment. Medications that are contraindicated with Fosamprenavir are listed below for your reference. For a more comprehensive list, please review Table 15A of the DHHS guidelines. Indinavir, IDV, brand name Crixivan, is dosed every 8 hours or twice daily when given with Ritonavir. When given unboosted, patients taking Indinavir must take it 1 hour before or 2 hours after a meal. When it's given with Ritonavir, it can be taken without regards to meals. This medication is no longer a preferred protease inhibitor. However, if there is a patient taking this medication, it is important to counsel them on the importance of staying adequately hydrated, as there is a high incidence of nephrolithiasis. The kidney stones that have been found in patients taking Crixivan are actually crystallized drugs and do not usually contain calcium oxalate or uric acid. Dose adjustment in mild to moderate hepatic insufficiency because of cirrhosis would decrease your dose from 800 milligrams every 8 hours to 600 milligrams every 8 hours. Medications that are contraindicated with Indinavir are listed for your reference. For a more comprehensive list of drug interactions, please review the Crixivan package insert, which can be found online. Lopinavir is the only protease inhibitor that is co-formulated with Ritonavir, as both medications are made by the same pharmaceutical company. LPV, brand name Kaletra, can be given either once or twice daily. Once daily dosing is not recommended, however, in patients with 3 or more Lopinavir-associated mutations, in pregnancy, or in patients taking efavirenz, nevirapine, Fosamprenavir, Nelfinavir, carbamazepine, phenytoin, or phenobarbital. If co-administered with efavirenz or nevirapine, the dose of Lopinavir must be increased. If patients are taking the tablets, they're to take 2 of the 200/50 milligram tablets and 1 of the 100/25 milligram tablets twice daily, or the indicated amount of the solution. The tablet formulation can be taken without regards to meals. However, it's important to note that the oral solution is recommended to take with food. This is the preferred agent during pregnancy, as there is the most clinical experience with this antiretroviral. Patients with cardiac conditions must be monitored if they are taking this medication, as it has been known to prolong the PR interval as well as the QT interval. Like all other protease inhibitors we have discussed up until now, it is metabolized by CYP3A4, and it also inhibits the enzyme as well. Medications that are contraindicated with Lopinavir are listed here for your reference. And for a more comprehensive list of the drug interactions with Lopinavir, I encourage you to review Table 15A of the DHHS guidelines. Nelfinavir, NFV brand name Viracept, is not used frequently in clinical practice. Given the availability of more potent protease inhibitors with a lower pill burden, this medication has fallen out of favor. It's either dosed twice or 3 times daily and must be taken with food. It's also important to note, in terms of potential drug interactions, it is metabolized by CYP3A4 and 2C19, and it also inhibits CYP3A4. This medication is not recommended in patients with moderate to severe hepatic impairment. Contraindicated medications are listed below for your reference, and I encourage you to review the more comprehensive list of drug interactions in the DHHS guidelines, which is Table 15A. Saquinavir, SQV, brand name Invirase, is one of the older medications and is also not recommended as part of an initial regimen. If given, it should only be co-administered with Ritonavir, and it must be taken with meals. If a patient has a pretreatment QT interval greater than 450 milliseconds, this patient should not receive Saquinavir, as it can cause QT interval prolongation and torsade de pointes. It is contraindicated in patients with severe hepatic impairment, and in terms of drug interaction potentials, it is a substrate and inhibitor of CYP3A4. The contraindicated medications that should not be co-administered at any dose with Saquinavir are listed here for your reference, though it is unlikely you will be seeing this medication in your clinical practice too often. Tipranavir, TPV, brand name Aptivus, must be co-administered with Ritonavir. It is dosed twice daily with 200 milligrams of Ritonavir twice daily. If given with the Ritonavir tablets, Tipranavir must be given with meals, and if given with the capsules or solution, it can be taken without regards to meals. And it is not because the tablets are less efficacious than the capsules or solution of Ritonavir, but it's mainly because the Ritonavir tablets are relatively new, and they may have not studied patients taking Tipranavir with the tablets and determined if the efficacy is less when they're not taking with food. This medication must be used cautiously in patients with mild hepatic impairment. However, it is contraindicated in moderate to severe hepatic impairment. It does have a risk of hepatotoxicity, especially in patients with underlying liver disease. Fatal and non-fatal intracranial hemorrhages have been reported, and this medication does require refrigeration, but can be stored at room temperature for up to 60 days. Tipranavir is metabolized by CYP3A4, and it is also an inducer. However, because it is always co-administered with Ritonavir, the net effect is that it inhibits 3A4 and 2D6. Medications that are contraindicated with Tipranavir are listed here for your reference, and for a more comprehensive list, you can review the same table as mentioned in the DHHS guidelines, 15A. And now that we've discussed all the protease inhibitors, let's pause briefly for a question. And I would encourage you to review, to answer the questions on the side panel, and as participants answer, I will call out what the correct answer is. All protease inhibitors interact with ergot derivatives, simvastatin, rifamycin, and St. John's wort. True or false? Okay, good. I have somebody who has responded true, and that answer is correct. Something to consider, there are several protease inhibitors with sulfa moieties. These agents are not contraindicated in patients with a sulfa allergy. However, a history of sulfa allergy and co-administering Darunavir, Fosamprenavir, or Tipranavir can result in a rash. However, the history of the sulfa allergy has not correlated with rash in these patients, and when they studied these medications, they did not exclude patients with a history of sulfa allergies. It is recommended to use with caution and to just monitor the patients. Adverse effects in the protease inhibitors. We've discussed all of the protease inhibitors, and now we're going to discuss some of the common adverse events. Atazanavir can cause elevated levels of bilirubin, which can lead to scleral icterus. It is important to warn patients of this potential adverse effect. Like Indinavir, it can also cause nephrolithiasis. Darunavir has been associated with rash and liver toxicity. Fosamprenavir can cause GI intolerance, rash, and there is potential increased risk of MIs with Fosamprenavir. We've already discussed that Indinavir can cause kidney stones, can also cause gastrointestinal intolerance, diabetes and insulin resistance. Lopinavir can cause GI intolerance, and there are some patients that do experience the intolerance with the GI side effects quite strongly with this drug class altogether. With Lopinavir, there is a possible increased risk of MI, and remember we discussed that it does prolong the PR and QT intervals. And Nelfinavir has been known to cause diarrhea. Ritonavir is a medication that can also cause a GI intolerance because that's really just something as a drug class you're going to see. It has been known to cause hepatitis. Saquinavir, remember, it prolongs the PR and QT intervals. And Tipranavir can cause the hyperlipidemia, hepatotoxicity, and there have been some reported cases of the intracranial hemorrhage. And now we come to the final antiretroviral drug class, the CCR5 antagonist. This medication targets the binding process of HIV to the host cell. A virus can express two different types of co-receptors that are necessary for the virus to bind to the host cell: CCR5, or R5 tropic virus, or CXCR4, which is X4 tropic virus. CCR5 antagonists selectively bind to the CCR5 receptor on the host cell membrane, which prevents the necessary interaction between HIV and CCR5, which then allows a viral entry into the host cell. This class only targets R5 tropic virus, not X4 tropic virus. Currently, there's only one agent in this drug class, that is Maraviroc. Maraviroc, MVC brand name Selzentry, is dosed depending on the concurrent medication. All concomitant medications must be considered when determining the Maraviroc dose. A tropism assay is needed prior to initiating therapy, as this will tell you which co-receptors a patient's virus uses for entry into the host cell. A patient may express CCR5, CXCR4, or both. Maraviroc can only be used in patients that have R5 tropic virus, not X4 or mixed tropism. To facilitate the discussion of Maraviroc dosing, I created this table. In the presence of potent CYP3A4 inhibitors, we're going to start with the inhibitors first. In the presence of potent inhibitors, Maraviroc is dosed 150 milligrams twice daily. If it's co-administered with the NRTIs, Invirase, Raltegravir, Nevirapine, Tipranavir, or Raltegravir, Maraviroc is given 300 milligrams twice daily. So if it's a medication that's not going to induce or inhibit, the dose of Maraviroc would be 300 milligrams. If Maraviroc is co-administered with a potent CYP3A4 inducer, it is dosed at 600 milligrams twice daily. Now you may be wondering, if you have an inducer and an inhibitor as part of a patient's regimen, if you should use the 300 milligrams twice daily dose? Well, the answer is that the dose would be 150 milligrams twice daily, as the enzyme inhibitory effects are the most significant in this case. This medication must be adjusted in patients with renal insufficiency, and if a patient experiences postural hypotension, the dose can be further reduced. It is not recommended in patients with renal insufficiency also taking potent CYP3A4 inducers or inhibitors. Postural hypotension can occur with this medication, and patients should be counseled on this potential yet important adverse effect. It does also have a black box warning for hepatotoxicity, which can be preceded by a severe rash or other allergic signs. Medications that are contraindicated are rifampin, and St. John's wort. For a more comprehensive list of potential drug interactions with Maraviroc, I encourage you to review Table 15A of the DHHS guidelines. As we've discussed in numerous occasions so far, this medication is prone to many drug-drug interactions because it is a CYP substrate, and its dose must be modified accordingly. It can also cause hepatotoxicity and postural hypotension, which we have already discussed, as well as the rash. And now we will stop briefly for another question. True or false? While Maraviroc is not a CYP3A4 inducer nor inhibitor, it requires a careful analysis of concurrent medications, and its dosing depends on drug interactions with other CYP substrates, inhibitors, and inducers. Yes, I see somebody has posted an answer here on the side panel, and the answer is true. That is correct. So Maraviroc its dosing depends heavily on the concurrent medications, and it's important to have patients disclose all concurrent medications that they may be getting from other providers before determining the correct dose. We have now covered all the antiretroviral drug classes, and I wanted to include information on combinations of antiretrovirals that are not recommended. Please review this important information, as these are combinations that should not be used in clinical practice. You should never see a patient receiving monotherapy with an NRTI, dual NRTI therapy, or triple NRTI regimen unless it's a patient that's receiving the combination of abacavir, lamivudine, and zidovudine. Components that are not recommended in combination include DDI and D4T, FTC and 3TC, D4T and ZDV, or any of these protease inhibitors specifically without Norvir or Ritonavir. If you'll recall from the previous webinar sessions, efavirenz is contraindicated in pregnancy, so you should never have a woman receiving efavirenz during pregnancy or in women with significant potential for pregnancy. This is also a refresher. Nevirapine should not be initiated in women with CD4 counts greater than 250 or in men with CD4 counts greater than 400. And etravirine should not be given with an unboosted protease inhibitor or with a boosted Atazanavir, Fosamprenavir, or Tipranavir. And also, the double combination of two NNRTIs is not recommended. And I realize that to absorb all this information with all these drugs and all these abbreviations and brands can be challenging. So I encourage you to review this summary table and use it as your reference as you review this webinar over again and as you read over the guidelines. So I hope you find this information helpful. And this concludes the presentation, and I'd be happy to answer any questions at this time. Thank you very much.
Thank you very much, Dr. Soto-Rosario. And I'm not seeing any questions right now. If you do have a question, you can always reach Dr. Soto-Rosario or any member of the AETC NCHCMC staff by emailing us at clinical@nchcmc.org. So thank you again, Dr. Soto-Rosario, and thank you all for participating in today's webinar. When the webinar is ended, a short evaluation will replace your WebEx browser. Please take a few minutes to complete this evaluation, as it will help us better prepare for future webinars. A link to today's recording will be made available shortly in the Virtual Learning Lab's Clinical Webinars page. While you're in the Virtual Learning Lab, we invite you to post follow-up questions in the clinical forum. Thank you very much, and enjoy the rest of your day.